Good to go.
All righty, welcome everyone. We are happy to have you join us for our virtual CME series. I think this is section 6 or so. I am Lauren Wilfing. I'm the MAFP Education Commission co-chair and a family medicine physician in St. Louis. We are very excited to have Dr. Breanne Lombardo with us today, who is an MD IBCLC clinical instructor at the University of Missouri-Columbia and a PhD student in translational biosciences. She's going to be teaching us about supporting breastfeeding and chest feeding families in primary care. Tonight's presentation is delivered live, and the presenter will be available for questions following the session. You're welcome to feel free to drop questions into the chat window as they come up during the presentation that we'll monitor and moderate them at the end, or you're also welcome to speak up and ask questions directly at the end of the presentation. Participation in tonight's presentation qualifies for 1 CME credit. The session will be recorded and uploaded to the MAFP YouTube channel for future reference, but to collect CME, it is only available for our live attendees. So please complete the very short survey at the link that Bill sent in the email introducing today's talk, and we'll also drop that in the chat towards the end of the session, so you have easy access to that. Information that we enter there will be used to report your CME to the AAFP. And just as a reminder, this is the 6th of 10 sessions that we've planned. So we have some more great ones coming up. So the ones that are coming up next are July 18th, we have integrating artificial intelligence, AI, into family medicine. We have a CDC update regarding HIV positive birthing persons and provision of human milk on August 15th. On September 19th, we have value-based care for family physicians. And on October 17th, I'm really excited about this one, primary care dermatology and skin of color. So look forward to those. Feel free to join us for which ones work with your schedule. As you find them as convenient and informative as I do, I'd also encourage you to nudge your partners to maybe join in with us. And if you love in-person CME, like I also do, we look forward to seeing you at our annual fall conference that we're having November 8th through 9th in Kansas City at the Intercontinental on the Plaza. So be our first year at that location. I think there's a lot of good energy about it. So we invite you to join us. So without further ado, I will turn it over and please welcome Dr. Breanne Lombardo.
Thank you. I'm going to put some slides here. Are you all seeing this slide, just the title slide? Okay, great. So I'll go ahead and get started. Like was already mentioned, I am a family physician and also an international board certified lactation consultant, training that I pursued during the medical school and during residency because I just felt like I just didn't know enough to help address some of the issues that I was seeing in my obstetric and postpartum families. And then a personal experience with my sister having quite the struggle with breastfeeding. So I really wanted to know more about how to help. So I'm happy to talk today. I wanted to start out just with a brief note about language. I try to avoid any strongly gendered language when it comes to breastfeeding because we just want to be mindful that we talk about provision of human milk or human milk feeding because we want to be inclusive in our language. Providing human milk might be done through exclusive pumping and bottle feeding, or it might be done direct breastfeeding. And then we should also not forget that we may have individuals who are do not identify as mothers or as women who are able to provide human milk for their infants too, and just to be thoughtful that there might be some things that don't fit neatly inside the boxes that we previously got. So just something to think about. And I just a plug for just asking if we're not sure what the parent's preference is or what terminology to use. And then I'll just go into just briefly why I talk about breastfeeding. And I mentioned already that I had some personal tie into why I wanted to learn more about it. But I think really the numbers speak for themselves. Although more than 80% in the US and in Missouri specifically, 80% of infants start out getting human milk. Less than 1 in 4 continue to 6 months as recommended. And then in terms of how parents feel about that, in multiple national surveys and studies, we see that the vast majority of moms or parents would like to breastfeed for longer, would have preferred to breastfeed for longer, and they're not able to meet those goals for one reason or another. There are a lot of unique properties that breast milk has that we just can't replicate with formula. And there are a lot of health implications for being able to provide that for infants. I mentioned that our numbers pretty drastically drop off in terms of breastfeeding rates over the first couple of months postpartum, down to about 25% at 6 months receiving exclusive breast milk. And then we also have pretty high rates of early supplementation with formula in the first few days, which can really undermine parent self-efficacy and feeling of ability to continue to breastfeed, and also future milk production. And from a medical standpoint, it has significant impacts on human health. The reduced rates of acute and chronic diseases for infants are pretty significant. So both infectious, like hepatitis media, acute gastroenteritis, lower rates of SIDS, and especially for the most preterm and most the smallest newborns, reduced risk of necrotizing enterocolitis can be life-saving for a significant number of infants. And in addition to the infant benefits, of course, something that I think receives a little bit less attention is the impacts on the parent. We have reduced blood loss and faster uterine involution, improved birth spacing, decreased risk of a number of different conditions, which adds up to quite a lot of saved healthcare dollars, reduced missed work related to infant and parent illness, and a lot of other economic and environmental impacts as well. From some estimates based on US and international data, the rate of breast cancer is reduced about 22% for women who breastfeed compared to those who don't. And if we extrapolate out for meeting some of the Healthy People 2030 goals and some of the World Health Organization goals, we're talking about tens of thousands of lives saved from being able to make a difference on breastfeeding rates. So I think it seems like it's an important health issue, clearly, and impacts families, infants, and adults. So I guess my next question is, why us? Why family physicians? I think this will be clear to most of us that we're uniquely positioned to be able to provide comprehensive care for parents and for infants. And a lot of us may provide perinatal care and make a difference in the prenatal education that our patients provide. And then also we're a significant portion of the first contacts that families will have in the early postpartum period, and then throughout the child's life as well, if we're doing the routine pediatric care. So we have a special focus and a special opportunity in that our scope of practice very naturally includes both moms and babies. We also know from Cochrane reviews and other significant studies that primary care interventions work when doctors and nurses and other healthcare providers are knowledgeable about breastfeeding and can help with it. It really does make a difference, and it can have health impacts. Parents really value their family physician knowing about breastfeeding and being able to help them with that. A couple of interventions that have been helpful in the past, led by UNICEF and the WHO, would be the Baby Friendly Hospital Initiative and the 10 steps. So the 10 steps of successful breastfeeding go over some key interventions that facilities and clinicians can use in order to best support breastfeeding. The 10 steps, I've included them here just to point out that family physicians interact with the healthcare system in a variety of ways and can make an impact in more than one of these steps. Whenever we look at our hospital policies and birth hospitalizations, our recommendations for supplementation, and then caring for mothers and babies throughout the postpartum period, we have several different ways where we can make an impact. So for the rest of the talk, and then until we have time for questions, I'm going to go over a few different things that I think will help us be able to provide more comprehensive care for breastfeeding, because all of us have it in our scope of practice to care for breastfeeding moms and babies. And we're going to talk about normal milk intake patterns, a little bit of review on lactogenesis, and review resources for medication safety, and discuss a few of the common complications that can occur during the postpartum period and how to address them. And then talk a little bit about ways that we can make our practices more breastfeeding friendly. So just a quick review on lactogenesis and the important hormone components. So estradiol and progesterone, of course, drive predominantly during pregnancy and cause the glandular development and production of colostrum in pregnancy. This is the lactogenesis 1. Lactogenesis 2 happens after we withdraw the high doses of hormones after delivery of the placenta and the increase in the quantity and quality of the milk. In stage 1, in the second half of pregnancy, milk synthesis occurs, and this is whenever some, but not all, pregnant individuals can express a colostrum. Ductal development increases so that each subsequent pregnancy, there will be ductal growth and differentiation that causes increased ability to make increased quantities of milk. Milk secretion, however, is inhibited at the point during pregnancy because of the high levels of progesterone and estrogen. Stage 2 is induced about 3 to 5 days after delivery of the placenta when those hormone levels drop, and then the release of the inhibition of those hormones allows the milk to quote unquote come in or lactogenesis 2 to occur. Later on, after about the first 4 to 6 weeks postpartum, the maintenance of lactation is kept by regular stimulation of the nipple and removal of milk in more of a supply and demand fashion. This is after several weeks of the hormonal control that happens in the early postpartum period. And oxytocin and prolactin are both really critical for those stages as well. So just a quick review of how this works for suckling, because I do think it matters when we think about disordered sucking patterns and different problems with latch. So the infant or a pump would stimulate the nipple that would signal the hypothalamus, which relieves the dopamine inhibition of prolactin release. So dopamine naturally is inhibiting it. That release of inhibition allows the prolactin to be released. When it's released from the anterior pituitary, it's going to go through the bloodstream to the lactocytes in the alveoli within the ducts of the breast in order to cause them to produce milk. There's some other feedback, like feedback inhibitors of lactation and other things that basically sense the fullness and emptiness of the ducts within the breast, but primarily this is the way that the milk production is stimulated. And then whenever the ducts are full of milk, oxytocin, also related to suckling or nipple stimulation, is released, which also travels through the bloodstream to the milk to cause the myopithelial cells to contract, causing the letdown or the release of milk. When we think about risk factors that for not producing enough milk or producing insufficient volumes for the infant to grow well, a lot of these risk factors we can actually identify during pregnancy. So prematurity, having the first baby, and long induction or augmentation of labor, especially with high volumes of IV fluids and long duration of induction, can also decrease the or increase the likelihood that it's going to take longer for that lactogenesis 2 to occur. Also, disorders of metabolism, metabolic syndrome like obesity, diabetes, and others, including gestational diabetes, and including an abnormal 1-hour glucose tolerance test with a normal subsequent 3-hour test, all influences the likelihood of being able to make sufficient volumes of milk and how long it's going to take. The reason I bring this up is we can identify some of these risk factors for poor milk supply or decreased production during the pregnancy and provide anticipatory guidance when we identify some of these patients in order to be able to help prepare them to be able to seek care in the early postpartum period. Of course, breast surgeries like augmentation, reduction, or lifts can also cut through the ductal structure and cause difficulty draining the breast or difficulty making enough. Certain medications, especially ones that influence dopamine signaling, like certain types of atypical antipsychotics, can significantly reduce the ability for prolactin to be released and for milk production, sometimes causing women on Abilify, for example, to not make much milk at all. For the infant, anything that can disorder the infant's regulation of their appetite or temperature or breathing or cause poor oral motor tone, poor suckling, can influence the ability of the infant to remove the colostrum and thus for the milk to come in later. Oral abnormalities like cleft lip or palate, they're not contraindications to breastfeeding, however, can make it difficult to create enough of an intraoral vacuum. Same with chromosomal abnormalities like Down syndrome. The low muscle tone can make it difficult for the infant to extract milk. In addition, when an infant has lost a lot of weight or is jaundiced, they may have low energy and be less vigorous at the breast. So all these things can be helpful for us to think about when we're providing anticipatory fluids. So when you're seeing infants in your place of practice, or in the inpatient unit or maternity ward or in clinic, a few things to think about whenever we're evaluating breastfeeding. First of all, I want to just emphasize the importance of understanding the family's feeding preferences and goals. It may not be every family's preference to exclusively breastfeed 100% at the breast. So we can be mindful of that when we're asking patients by just asking them, what's your plan to feed your baby? And how long were you planning on feeding your baby that way? We can determine if the intake up to that point has been adequate for growth by looking at growth curves. And we'll go over some other tools that we can use as well. Evaluate the milk transfer. We can understand something about the milk production or the transfer, but usually not both based on the growth. Usually requires some more investigation to know, is the milk there, but the baby's not removing it, or is the milk not there, or the milk used to be and the baby's not removing it, and so the supply is downregulated. And all those things can get pretty complicated, but when you think about it, it's really just production and transfer, and then being patient-centered and family-oriented, and thinking about how to make these plans. Women, parents will go to extreme lengths to make breast milk and spend lots of money on supplements and things, and really sacrifice a lot of their mental health and sleep in order to do this. And we have to be mindful and not necessarily support someone not taking care of themselves. We really want to value the maternal well-being above the provision of milk, right? This is something that can be very sensitive as well. And then together with the patients, make a realistic family-centered plans that considers the maternal mental health as well. When we ask about the history, we're thinking all the things you already know to ask. How often is the baby eating? In what manner? For how long? How's the baby's behavior? Are we seeing any grunting, trouble breathing, excess spit up? How many wet diapers and stools? Really thinking about what is the milk intake been like. And then especially in the early postpartum period, has the milk come in yet? Have you felt the breast increase in fullness? Are you dripping milk? Is there any pain or discomfort with feeding? When we do an exam, I really want to look at the infant, of course, as you would for any well-child visit, and look for hydration and look at fontanelles and mucus, all your regular things. And then also I'd like to see the baby at the breast. I'd like to see how the mother is holding the infant, how comfortable they feel with positioning. Do they feel timid? What's their affect? How are they interacting with the baby? And then the latch itself. How is the infant positioned? Are they, is the body in line? Does the infant seem at ease? Does the mother seem at ease? Do I notice sucks and swallows? Am I noticing that the mother's wincing in pain? And then looking at the nipples after the feed, what do they look like? Are they bruised, wounded? Are there scabs or sores there? And then often, but not always, we'll weigh the infant naked and then have them feed, and then weigh the infant again, subtracting the weight of the diaper, but leave the diaper with any contents in it when you weigh the baby, and you can approximate the transfer of milk by about 1 gram equal to about 1 ml. So in terms of evaluating the breastfeeding, we, let me skip forward just a little bit here. So I'm going to talk a little bit about how to adjust for latch and how to make that more comfortable for moms, but we'll come to this part first. So I want to give caution. So in this, especially those first couple of days postpartum, it can be easy just to recommend supplementation without really understanding what the balance of production and infant milk transfer is. And so I really want us to come back to thinking about physiological volumes. And in the first couple of days, although I don't recommend weight-based dosing of breast milk because it's not necessary, really the volumes in the first 24 hours are quite small. When you think about a 3 kilogram baby, somewhere between 2 to 10 mLs per feeding. So when we recommend a supplement, for example, for a baby with excessive weight loss at day 3, the noted volume here for a 3 kilogram baby would be 15 to 30 mLs. That's for an entire feeding. And what I like to think and explain to parents is that whenever I evaluate the milk transfer at the breast and I get a sense of what the breastfeeding has been like at home, if I think about a full good feeding for the average baby being 15 to 30 mLs, I'm not going to recommend that they supplement 60 after feeds. It just doesn't physiologically make sense, and it can really set up families for failure when it comes to the infant being overfull and not really very interested at the breast. And it can also set up families with a kind of overestimation of how much milk they should be making when they pump and get 15 mLs, and they're like, oh man, I'm really failing. So I think understanding this and talking to families about the gradual increase in volume and what the normal levels are, and being able to estimate approximately what amount of the infant's needs are being satisfied in each feeding, and then adjusting your counseling accordingly. So at day 3, an infant that's breastfeeding fairly, I might suggest that they do 15 mLs after feeds, or 30 at half the feeds, or something like that. So that I'm not trying to overpower the breastfeeding relationship by supplementing to excessive. So I think this can be helpful to think about the appropriate volumes, and these tables are available online. This is from a 2013 publication, but there are several available. And for our residents, I often say, I think the first few days, 5, 7, 14, 21. So when we think about 5 to 10 the first day, I just in my mind think 7 per feed the first day, 14, approximately 15 the second day, and then 21, 20 to 30 the third day. So I think that kind of helps us to kind of not overpower with the volumes. And then later on, 1 to 2 ounces is really reasonable for a feeding. And so if you anticipate that the baby is getting a little bit of milk at the breast, you can cut that in half and adjust as needed. I think, and also just reassurance about the first couple of days can be very rough, and the feedings don't have to be great. 4 to 6 decent feedings the first day of life is actually pretty good. We don't need to jump to supplementing because we can really undermine what's the good stuff that's going on. As we all know, infant weight loss is totally normal. Almost 5% of newborns born vaginally lose more than 10% of their weight, and that's within the realm of normal for some infants. We really want to look at the big picture and think about signs of health, signs of hydration, has the milk come in, what happened during the labor and delivery process that might cause that infant to diurese more significantly. For example, mom got 6 liters of IV fluids, and while baby was in utero, baby's definitely going to diurese and have some excess weight loss. So when we think about these curves and how much weight loss is normal, it kind of leads us away from thinking, well, 10% is my cutoff, I've got to supplement after we've lost 10%, understanding that, a decent number of newborns will have that weight loss and it be totally normal and healthy. The newborn weight loss tool, I think, is a good way to think about this in percentiles, and we at MU are using this for our newborn nursery and the first 30 days to kind of help us put this infant's weight loss in the context of the population. The percentile curves don't really matter so much, because if a baby follows it, then that's considered within normal limits. You have the percentile curves from 50th at the green all the way down to red, and this tracks the infant's weight as it goes down in the first 30 days postpartum. And if we are starting off at the 50th and then we go down to the 95th over the following 1 to 2 days, it's not normal. We've got a problem with milk transfer, we've got a problem with milk production, or some combination. But if we start at the 95th, the environment in labor and delivery can have a significant impact on that. And if we stay on the 95th percentile throughout those following couple of days, nothing really significantly to be worried about. We need to continue to support and promote effective feedings, but we don't have to be alarmed and don't have to start supplementation just for that reason. So in that sense, when we think about supplementation, because it really can have a significant role on how much colostrum is removed, because we make the babies very full, they might not suckle as well, and so forth. We do want to limit to those volumes that are physiologically normal, and continue to stimulate the breasts. Now, there's only 24 hours in a day, and parents can only do so much. So if we're pumping and bottle feeding and breastfeeding, there comes a point when we really have to think about what's a practical number of times to breastfeed, what's a practical doable number of times to pump, and so forth. But we want to stimulate the breasts at least 6 times a day, or more if we're trying to increase. We want the infant to be able to practice at the breast, but if they're not transferring very well, letting them breastfeed 15 times a day doesn't really help anybody. It wears everybody out. So we want some practice, not too much, not too little. And then we want to think about whether the family has access to express milk. So if the parent can express and provide that colostrum or provide that pumped breast milk, or they have informal milk sharing or milk from a milk bank, all of those things are preferable to providing formula just because of the increased risk associated with that. We can use a variety of different options to feed babies. I am not opposed to bottles. I think bottles are obviously a great way to feed babies, but for parents that are very concerned about nipple confusion and all these other things, then they may be more, they may feel more comfortable with some of these other methods. You can see in the photo, like finger feeding with a syringe, or finger feeding from a bottle. You can use a cup, and the infants more or less just kind of laps it out of the cup. We're not talking high volumes in the first couple of days, and so all of these can be effective ways. At the bottom left, you can see an infant feeding at an at-rest supplementer. This baby's obviously a little bit older, but this is called a supplemental nursing system. And so your families may be interested in something like this if they're providing larger volumes of supplement, especially if the infant can latch well. The infant can latch and the volume's a problem, then the at-rest feeding stimulates the milk production as well as gets the infant fed, and can often have a positive psychological impact on the parent that gets to direct feed versus bottle feed. That was what they were. I like to talk about paced bottle feeding and not exceeding the normal pace of feeding at the breast in order to not give infants that preference for high fat flow. And then the triple feeding that I've already kind of alluded to is a very common thing that is recommended to feed the baby at the breast and then pump and then supplement for each of the feeds. I do give quite a bit of a caution for recommending that just because of the pretty significant mental health impact that it can have on loss of sleep. And it leaves very little time for that lactating parent to do like anything else. So, and again, kind of when we think about what families want, what they're trying to accomplish in the context of their family, what their family can tolerate and the parent's mental health can tolerate, especially in the setting of low milk supply, we want to set individualized goals. So we mentioned about needing for supplementation with excess weight loss or jaundice. And sometimes this is related to the infant losing weight before the milk has come in, which that's just some infants, I like to explain it. Some infants can wait and other infants seem to not be able to wait as long for the milk to come in. This normal time being around day 3 for multiparas and day 5 for nulliparas. We want to think about not only just the weight curve, not only just the percent weight loss, but we want to also look at the infant as a whole. Are there other signs that intake is inadequate? And then, like I mentioned earlier, think about whether it's likely to be a transfer problem, like the infant is having ineffective suckling at the breast. And we'll talk a little bit about what your clues are for that. Or is it a supply problem, or maybe it's both? We want to think about retained products of conception. Don't forget that we're the doctor for the mom as well, and we need to think about her health and any other conditions that might influence her ability for her milk for lactogenesis too. So all the hormones that we mentioned, medications like estrogen or progesterone can certainly inhibit those, just like they do in pregnancy. They can do that postpartum. So early medications can play a role. And then think about things like anemia, a hemorrhage after delivery, retained products of conceptions, etc. So you think about whether we want to just get some blood work to evaluate the low supply. I think about getting a CBC, a TSH, and then perhaps a post-feed prolactin, which should be over 100, which would be the sign of that pathway effectively working. I think I mentioned this already enough. I really want us all to be very cautious about recommending triple feeding. I've talked to families that have been doing it for months. They haven't slept. They haven't, been able to really enjoy time with their infant because of this process, very involved feeding. I'd recommend only using it as a last resort and instead make a plan to feed the baby what the baby needs. Make a plan to remove the breast milk to stimulate this production, and then make a plan to keep the baby familiar with the breast separately, rather than trying to do all of the things all of the time. So just to plant that seed. When we think about, because I kind of started early on talking to you about why one of the reasons I think this is such an important issue is so many families stop breastfeeding before they meant to, before the parent wanted to, before it was recommended to stop for the WHO and all of the other professional societies. People are stopping, and why? Oftentimes we can go back to, what happened in the birth hospitalization, and we just didn't have good colostrum removal in the first couple of days. The milk maybe came in on day 5 to 6, but we were already supplementing, and we didn't have a good latch. You can hear these stories, and there's a lot of common themes there. We also know that in research studies, the most common reasons for moms are that they were having pain. So pain with latch or pain with pumping. They didn't think their baby was getting enough. They either thought the baby wasn't growing or the baby was fussy, crying and having gas pains, and they were pretty sure that it could have been from the milk. They have medication safety concerns, for example, they don't know if their medicine is safe to take, and so they just stop breastfeeding for that reason, or they just encounter a culture that's just not that supportive. They run into barriers at work with pumping and milk storage, a lot of the lack of paid parental leave and lack of workplace support can really influence how long parents are able to do this. So I think this are each ways that we can intervene and help families to navigate the healthcare system and navigate some of these challenges. We hear a lot about early engorgement in the first couple of days, kind of, and folks being concerned that it's pathological when really it's actually normal. It's very normal to have engorgement the first few days, but even the first week postpartum, if things are going perfectly, you'll have engorgement. We want to facilitate regular milk removal, so feeding the infant via the usual method, but we don't recommend pumping extra to treat engorgement because all it does is just remove the colostrum or the transitional milk and then moving it more. Pumping to empty actually is not really a thing because milk production is a 24-hour business, and so you're never really going to get fully to empty. The flow might slow down, but that's a different thing. So, and we want to upregulate, if we want to upregulate supply, of course, we're going to empty more frequently, but if in the case of engorgement, it's actually not what we want. The view of how we treat engorgement and mastitis spectrum, and really it has been a shift to think of it as a spectrum, changed over the past couple of years, especially with this Academy Breastfeeding Medicine protocol that was published in 2022. And essentially, we're not recommending heat. We don't recommend massage. We don't recommend emptying the breast more frequently. We do recommend feeding the infant how you normally would. It's okay if there's engorgement or mastitis to feed the baby. The milk is safe. And we recommend ice, anti-inflammatories, Tylenol, and actually give the breast enough rest. So if you're pumping extra, actually stop that. Do ice and cold compresses in order for comfort, and just feed and pump just to comfort or what the baby needs. There is some lymphatic drainage that can be used. Essentially, with a lot of engorgement, it's actually not the milk ducts we're feeling. The milk ducts might be full, but it's actually the subcutaneous fluid that is causing the vast majority of the pain and the symptoms. And so when you think about that fluid being able to go up away from the nipple, it can actually cause it to be more effective milk removal when the infant latches or when you use a pump. And so in small circles up away from the nipple, up towards the axilla, can actually be really, really helpful and a very powerful way to quickly relieve engorgement, especially paired with ice or cold compress afterward. And this is from the Physician Guide to Breastfeeding, one of the links that you'll have in the slide deck that has a lot of helpful resources for parents. And for us, I find myself looking at this side a lot. When we think about nipple pain specifically, the vast majority of cases is probably ineffective latch or too shallow of a latch. If the nipple comes in contact with the infant's hard palate, it hurts. The natural position of the nipple in the baby's mouth would be back at the soft palate, actually kind of below the upper jaw, where it moves freely within the mouth, but it doesn't impact anything hard. We really don't want, we want to avoid, or I highly would recommend avoiding treating nipple pain generically with multiple prescription or generic products. You'll often hear people use triple nipple or all-purpose nipple ointment. It's an antibiotic, it's an antifungal, and a steroid together. I would highly encourage you to think about which one of those things the patient actually needs and use that one. It's rare. I don't think I've ever seen somebody have a fungal and a bacterial and a dermatitis all at the same time, right? But this is what's commonly done in the community. And really, I think what happens is we end up having contact dermatitis from all of the creams and things that's further compounding the issue and making it more complicated. So really put on a doctor hat when it comes to the nipple pain and look for dermatitis. It can be allergic, it can be traumatic. Sometimes steroid is appropriate, but avoid just putting the kitchen sink at this. Of course, we want to think about ankylosing or tongue tying whenever pain is not improved with repositioning. If we can't get a proper latch and then the infant's tongue is restricted, then that might be an appropriate candidate for a scissor frenotomy. There's a Academy of Breastfeeding Medicine protocols, which I highly, highly recommend. They're super helpful, packed full of info. There's one on persistent breast and nipple pain, and there's also one on ankylosing that goes into more on troubles with breastfeeding and nipple pain from both of those things. When we think about latch, considering that this is the most common reason why folks come in and have pain with latch, I wanted to just hit a couple of points on how we can most effectively get the baby to latch comfortably for the mom. So you want mom to be seated in a comfortable position. If they're home or you do home care, I love that if you do it. But if the parent feeds sideline, that's also very effective, like you can see in the bottom picture. But usually in the office setting, they're sitting up, they're comfortable. We actually have a little footstool that we offer to put under her feet. And we have a breastfeeding pillow support that we can put around the waist in order to really support the baby so that she can lay back. The baby, you want the infant's ears, shoulders, and hips all in a straight line. We don't want the head turned and the body turned away from mom. We don't want kind of the legs hanging off of the seat because, of course, this can elicit some of those newborn reflexes that are just not helpful for breastfeeding. If the baby's doing a Moro reflex, it's not helpful, right? If we're rooting because we're touching on the face, it's not helpful. We want the infant to be belly to belly with mom, the ears, shoulders, and hips in a straight line. And this really applies for any of these positions. So cradle, football, cross cradle, the baby's facing and hugging mom, belly to belly, or belly to mom's trunk. The infant nose before latching should be in line with the baby's the infant nose with the maternal nipple. And then you bring the baby to the breast rather than the breast to the baby. This limits the tension and pain in the mother's neck and shoulders, and also allows for not to be significant like breast management and holding throughout the duration of the feed. You bring the baby to the breast and then the baby can latch. I often recommend tickling the babies or prompting the baby to latch by touching the nipple to the baby's upper lip or to the nose. When the baby opens wide, you bring the baby close. The chin should touch the breast. And so, like I said, we use props in our clinic. We have a breastfeeding pillow and a footstool, and it's really helpful. And a lot of parents will comment like, "Oh gosh, I need to get a stool by my couch just to make this so much easier." And so sometimes those things help at home too. The latch, a good latch, if you look at a baby breastfeeding and you say it's a good latch, it's usually because it's asymmetric. So the nose you can see is away from the breast, the chin should be touching the breast. And then there's more of the subareolar tissue in the baby's mouth compared to the areolar tissue. So when this is what I was talking about with the nose to the nipple, and then the baby opens wide and you bring them close, the nipple goes back to the soft palate on the baby. This is your typical deep asymmetric latch. When you're looking from the outside, you see that bottom lip flanged open, the top lip, maybe not, doesn't matter quite as much. But you see that there's a good portion of areola in the baby's mouth. And there's breast tissue, it's not just the nipple for sure. For babies that have a hard time with this, for example, they have a small jaw, they have a small mouth, mom has a flat nipple, those sorts of things, you can do what we call the exaggerated latch, or I'd call it the flipple, like flipping the nipple up. And you prompt mom to use her thumb to point the nipple upwards so that as the baby, it really just exaggerates that baby getting the subareolar tissue in their mouth. And the nipple points up as the baby comes towards the breast, and then that nipple will be farther back. And I cannot tell you how many times this fixes the painful latch. Like, oh, this is it. So really simple body position corrections, chin and head orientation towards the breast, and then exaggerating the nipple position in order to get it farther back. Immediately, parents will notice a difference in how this feels. Now, if these things aren't working, we need to try some other things. I will remind you that this sideline is very helpful for especially those early few days. And I highly recommend it, and having another adult who's not sleeping, who's going to be awake, watching in order to remove the baby and put them in a safe sleeping location if mom falls asleep, because that can be a very comfortable place to fall asleep next to the baby. So in terms of the pain from latch, some of these are some techniques. There's some videos. The IABLE has a great latching video and case bottle feeding videos and lots of educational content. So I often send those links to patients as well. Despite our best intentions, a lot of moms will develop wounds on their nipples, and you can see some pretty significant ulceration, broken skin, scabs, bruising. You can see pump trauma, all sorts of things, and you kind of can start to understand the pattern of things, but then you think, well, what do we do about it? Is that baby really going to be able to latch 12 times? How is this going to heal if a baby's feeding 12 times a day on that spot? The nipple, thankfully, is very resilient tissue and highly vascular, which means it has actually a low rate of bacterial and fungal infections, and it heals really well given the right environment. So the two main ways that we think about healing nipple wounds related to breastfeeding are if we have a wet exudative wound, we need to absorb some of that moisture and let to support the healing environment. But that's rare. I'll say the vast majority of cases we see a dry wound and we need some extra moisture there. So Medela, no, I'm not plugging this brand. It was just one of the pictures I found online. A lot of different companies make hydrogel dressings, and these are very effective at healing breastfeeding wounds. So even actually just nipple soreness, they can be helpful, but even more so, a lot of the surgical literature, there are some data on how a moist healing environment with a hydrogel can heal wounds pretty fast, and the nipple is no exception. Whenever women have, especially a dermatitis and a wound, I like to ask about what they've been putting on the nipple before then. Oftentimes it is lanolin, and it can be allergenic in up to 20% of patients. So I will often just say, okay, let's stop the lanolin because it's an allergenic component that we're putting on broken skin. It just increases the chance of dermatitis. And then we have two things going on. We have the wound and we have the dermatitis, and it gets just challenging to see what's going on. If you switch to something hypoallergenic, like a lot of the organic nipple balms will have very low numbers of ingredients and things that aren't as likely to be allergenic. I think there's a couple of manufacturers also that make a hypoallergenic nipple balm that you can recommend as well. And you put that underneath the hydrogel. I'll tell you that the hydrogel literature in the box will tell you don't put anything under it, but this in the surgical literature, this has been used for a long time for wounds, as you may know. So, but really we want to think about the cascade of events. So were we having a shallow latch, nipple trauma, nipple wound, pausing direct feeding, pumping, and then now we have pump trauma, and then we put lanolin on, and then we're getting a contact or allergic dermatitis. So the picture can be really messy, but when we kind of tease apart these different things, you can usually come up with a reason for why the nipple looks the way it is. And with 3 to 5 days of very between feeds, hydrogel and balm is will usually heal. You can use Medi honey because it's autoclaved and it's not dangerous for the infant. And if you have a dermatitis, you can certainly use triamcinolone. I'll often use that 0.1% triamcinolone cream or ointment, and it's safe for the infant as well. Absorbs really quickly and doesn't really cause any significant problems. So when we think about the cause, again, I mentioned it can be a whole cascade of things, but really usually the number one thing is correcting a shallow latch and then providing the appropriate wound care for it to heal. Oftentimes women are pumping, and you can see quite a bit of pump trauma as well. One way to recognize pump trauma as opposed to an infant latch trauma is that it can be circumferential around the nipple and can include the areola. So if you have the shaft, more so to speak, of the nipple with circumferential wound, then that can be from a too small of a flange fit. So the plastic piece where the nipple moves in and out for the pump, if it's touching the sides, it's going to cause trauma. And if the flange is too large, you can get circumferential areolar wounds and actually suction blisters and things on that. So just inquiring about the way that the nipple is moving in the flange, you can make a huge impact on not only the comfort and the presence of wounds, but also on the milk production. Because if the areola, you can imagine if all those ducts feeding into the nipple are actually being compressed before the nipple because the areola is being suctioned too, it's not going to cause very effective milk removal. So the nipple should just move in and out of the flange because that's the elastic tissue. The areola doesn't have any elastic tissue and should stay more or less put. And you want the flange to suction against the brush, and you shouldn't really see or hear any air movement around the breast or around the areola. Most of the pump manufacturers will have their size guides. So Medela, Spectra, and so forth will say if your nipple measures this, then use this size. And so sometimes on request we'll measure nipples, and you usually add 3 to 4 millimeters to the nipple size in order to get the appropriate size flange. But honestly, trial and error is actually probably the better situation because you can see, as it is in these photos, you can see when it fits right. And parents can know this. Once you explain this this picture, and I usually just pull it up and show it to them, they're able to fit themselves at home by trying a couple of different sizes. We do in our clinic have some different sizes that they can sample and try, which is nice. Some of these pieces are so expensive to keep buying them. So that's helpful if you can do that or have somebody that does, maybe if the width close to you offers something similar. So we talked about early volumes. We talked about some common causes of nipple pain and wounds. And one of the other more significant reasons that women stop later on, say 2+ months postpartum, stop breastfeeding is because they're not making enough. I actually should clarify, it's because they don't think they're making enough, not because they're not. And so sometimes addressing some of the knowledge of what an infant needs as they grow and how much milk is the normal amount of milk can be helpful, because oftentimes, probably just as often as not, the volume that they're making is fine. It's the perception of the infant behavior, the perception of how much milk they should be making that causes them to doubt whether they're making enough milk. So in general, from month 1 to month 9, the milk production is relatively stable. So that means that unlike formula feeding, the amount of milk in each bottle as a baby gets bigger and bigger does not increase. When we think about the growth curve, the growth slows, the growth velocity slows, I should say. And so the amount of milk per pound of baby decreases. The amount of milk that they actually take stays relatively stable. So from month 1 to month 9, it's about 24 to 30 ounces of breast milk a day, or about 1 to 1.25 ounces per hour. So when a baby is growing well on 24 ounces of milk, that's actually normal volume. So what that might mean is, especially if the parent is at work, they might pump about 10 ounces during the workday. And that's a perfectly normal volume when they feed on demand the rest of the time. So the evening and maybe overnight feed and feed before going to work. That's really normal. And so kind of counseling families on that 1 to 1.25 ounces per hour whenever they're separated from baby can be really helpful, as well as just looking at how the normal patterns of milk intake go for the first year. So in this graph, you can see how it increases really dramatically up to about 24 to 30 ounces. And this is in milliliters, so 750 milliliters. Stays relatively stable until infants start solids, and then very gradually decreases after starting solids, and to about around 16 to 20 ounces between 9 and 12 months. So it's really quite lower volumes than what we're used to feeding formula-fed infants. And this, again, is assuming that the infant is eating solids well from month 6.5 plus and on. And so this kind of goes into some of the recommendations for cow's milk levels. At 1 year, we talk about 12 to 16 ounce limits. That's actually very similar to the breast milk intake for normal breastfed babies. So I think oftentimes when parents are they're stressing about milk production, or they're trying to make more milk, there are a lot of factors that can go into that. For example, if a baby starts sleeping through the night and we're not emptying the breast overnight, the production can go down. If we do sleep training, the production can go down for some people if they don't empty the breast through the night. When we start solids, when parents go to work and are separated from their baby, and maybe the carers at the daycare or grandparents, or whoever it is, are feeding 6-ounce bottles, right? That is going to make the milk not seem like it's going as far. So there are social and cultural influences that may influence this as well. So it can be complicated for sure, but the 1.1 to 1.25 ounces per hour per day during the day is pretty standard. So when we think about, I've got a few more things I want to get through. I know we're getting close to time, and I want to leave time for some discussion as well. I want to just briefly talk about some resources for medication safety. And essentially, it's almost never necessary to say to pump and dump. Now, there are some exceptions about this. And if you're not sure, I would just caution you to say pump and save, pump and mark the bag, save it, put it in the freezer while we're investigating a little bit. There are some apps where you can use to find some information, like this is the Galactipedia app. I have a couple other that I'll recommend that you use. I usually look at 2 or 3. There are some meds that are, of course, harmful to baby. Antineoplastic, so chemotherapy, radioactive iodine, and a couple caution about meperidine and codeine, as well as testosterone pearl. So those things actually are dangerous for the baby, and these are rare situations. I'd argue we usually have an alternative for codeine, for example. We have an alternative for Tessalon pills. I guess we could argue about whether it actually is helpful or effective anyway, right? So those are things that we can work around, but antineoplastics and things are certainly a concern. There are some other medications that are harmful to milk supply. For example, estrogen-containing birth control, Sudafed. Those are going to, some antihistamines, especially in higher doses, can reduce the milk supply. So there are things that we want to avoid or limit, but almost anything else is compatible with breastfeeding. And there are no contraindications to use our radiographic studies. Patients can get a mammogram, they can get MRI, they can get CT, they can get anesthesia without it being incompatible with breastfeeding. The vast majority of all the anesthesia that we use in today's day and age, when mom is awake and awake enough to hold her baby safely, she's safe to feed her baby. So a lot of these medications are not harmful, and parents should be allowed to pump or feed their baby in the recovery room. This graphic on the right is from the anesthesia professional societies, and they put out a statement talking about the safety of these medications as well. I mentioned there are several places to look to get medication safety, so we should never say, well, I don't know, just dump it just in case, right? Because we've got a lot of places to look. I like LactMed, and Google searches LactMed better than LactMed searches LactMed. And so what I do is I just go to Google and I say LactMed plus med name, and it'll take you right to the article. It's usually pretty fair and balanced. It will cite the literature. It'll tell you how many case studies were present, and it will give you a recommendation. I usually go to that one plus infant risk, and they have a really nice iPhone or Android app. I think it's maybe $5 for the year or something like that, not very expensive. And I usually cross-reference both because Hill's, my experience, is a little more conservative. LactMed will just cite you the evidence and you get to decide. Elantensia is another one. It's a little bit more, less conservative than Hale's. And so I like to look at all three and make my own choice, right? We get to do that, and then talk to parents about, well, this is what I'm reading. This is what I think. And especially with elantesia, this is what this graphic at the right is for. Maybe this, I like this one because it can talk about antipsychotics, which a lot of us think as being maybe not compatible with breastfeeding. There are some of these that are green, but are actually very low risk. And so when we are choosing on a course of treatment, or deciding on a course of treatment, we can actually use some of these resources in order to choose a med that's a little bit safer. And then the Trash the Pump and Dump website is really great too, to get some information about medication safety. So between all of these, I like to look at 2 or 3, and I'm landing somewhere in the middle between all these resources, but I think it's really helpful. So none of us should ever say, well, I'm not sure, just pump and dump, especially if it's a medication that we give to babies anyway, right? So something like amoxicillin, we use in infants all the time. I heard somebody not too long ago that they told them to pump and dump their milk for amoxicillin. No. And the amount that the baby gets, you can look up the protein binding, the molecular weight of the drug, and then the relative infant dose. And you could say, oh man, like the infant would have to consume gallons and gallons and gallons of this super concentrated milk in order to have any meaningful impact. And so it's just not practical. So a lot of the things we can just relax, and the med safety is a lot more reassuring than we previously thought. So hopefully that's helpful. And then just, I guess this is the last thing, and then we'll have a couple minutes to talk and ask questions. But really, when you think about breastfeeding friendly office, I think it's creating an environment for not only you and your staff and your patients, but an environment that is promoting breastfeeding, but also promoting the parent's choice and family-centered care, and people are knowledgeable, and not only just promoting breastfeeding, but can actually support and solve problems. We want to provide support throughout the infant's lifespan. The American Academy of Pediatrics has now matched, and the AFP as well, has now matched what the World Health Organization has said for many years, that breast milk till age 2 is beneficial. And so we should be supportive and inclusive in helping families solve some of these issues that come up. And of course, if you are accepting formula, it's not recommended by the World Health Organization to give away free samples of formula, because it kind of really undermines this whole efficacy of families, and can give messages that we don't need to give. I've got some links here of all the resources that I've mentioned already. And then I'll just go, we have a couple minutes left for questions. So thank you all.
Thanks, Dr. Lombardo. We will certainly open up for questions here. We have one in the chat, says, do you recommend using nipple shields to help with latch or to prevent wounds?
That's such a good question, and I feel like it's such a catch-22. I definitely counsel about pros and cons of nipple shields if parents want them. You will see in the Academy of Breastfeeding Medicine in their late preterm protocol, they do recommend considering nipple shields specifically in late preterm infants. And we think about like the mouth is small, the nipple is too big for them because they're so tiny. The nipple shields actually are very effective in that population. Otherwise, for wounds, the problem I see with nipple shields for wounds is it doesn't make us confront and diagnose and treat the problem, which is usually a poor latch. It's usually a shallow latch, and the nipple shield will not only protect the skin of the nipple, but it also blunts that hormonal feedback mechanism that slide that we showed early on that leads to effective signaling through dopamine pathways. So I think it can lead to decreased milk supply if we don't also pump or remove milk and provide some other avenue for nipple stimulation to get the proper hormone signaling. So it's great. I recommend them all the time, like 35, 36 week babies that just are really having a hard time. And I think it's great in that setting, but otherwise I really try to avoid it because I try to fix what the latch problem is. It can be, if we do use them as soon as possible, getting off of them, I think is really helpful. So do good wound care. So as soon as the nipple is healed, moms are sometimes scared. They're like, oh, I cannot deal with the pain I was dealing with before. I can't drop the nipple shield. But we just have an open mind about it. And I say, let's try. Let's see what happens. Your nipple's healed. Let's see what happens. Let's really be very good about getting good positioning and a deep latch. And parents are often surprised. The longer we wait to get off of them, the harder it is. So there are kits online for transition off nipple shields where the nipple shield gets smaller and smaller and smaller. It can be an ordeal. It can be a month-long ordeal if they're not dropped early on. So it's a pro and a con, but yeah, sometimes they do.
Great, thank you. Likewise, what are your thoughts on, occasionally I hear people say, put some breast milk on it in terms of nipple lesions or pain or infection. What are your thoughts, and is there evidence one way or the other?
I don't think there's evidence one way or the other, at least not that I know about, but I know it's not harmful, and it's certainly not going to cause any allergic dermatitis that we see with some of the other things. So I'm all for it. I will say for wound healing and specifically, you can express breast milk and put it under, for example, a Silverette or a silver nursing cup. And that seems to be effective. It'll also help underneath hydrogel dressing. So I think in conjunction with the other things, yeah, it can be really helpful. It's non-allergenic. It's moisturizing the skin, has lots of IgGs and helpful proteins and things in it. So I think, yeah, I think it works, but I don't have the evidence for that.
Do you have any comment or advice about tongue-tied and frenotomy?
Yeah, I think it's a hot button issue for sure. I do scissor frenotomies, but actually less often than you might think doing breastfeeding medicine. In my experience, it's usually not the frenulum that's the biggest issue. And I guess I've seen quite a few babies that have the tongue tie clipped and then have it revised, and they're still having trouble breastfeeding. And then we get back to basics, and we can correct a lot of that by body positioning and getting a deeper latch. Now, not all the time. Sometimes there's a clear frenulum, and you're like, there is no way that that tongue can move how it's supposed to move. And I do a really detailed oral motor exam, and I talk to parents about, how sure I am that the procedure is going to help versus what are the risks, and we just have an honest conversation about it. But if the tongue cannot lateralize and it can't raise, and whenever they latch onto a gloved finger, there's no peristalsis, and there's an obvious frenulum, then I think that's a slam dunk. Like, yeah, we should probably click that and try it. But I think this is consistent with the Academy of Breastfeeding Medicine. I don't recommend any laser procedures. There's just high risk of thermal injury, not only thermal injury, and then feeding aversion, and it can cause deeper wounds than we make with just scissors. And so the Academy of Breastfeeding Medicine and their ankle velocity protocol has a section on that. There's no evidence, no evidence on the laser treatments. And it's quite the booming industry for sure. But but it's usually done in combination with very extensive, what we call body work, or like, you know, upper body therapy, exercise and stretching, which I would argue is usually, I'd say we have a more of a plausible mechanism for that helping than with all of the androgen releases. So scissor phenotomy, yes. Sometimes whenever we're pretty sure that the tongue is very restricted and we have nipple wounds and pain plus poor transfer, then yeah. And really in the grand scheme of things, it's a pretty low risk procedure done with scissors. Laser, not so much. But yeah, we do them. It's just, you'd be surprised, we just don't do them that much. One of my colleagues has done breastfeeding medicine for 5 years, and she's managed to never do phenotomies because she's, I mean, I guess it could, maybe most people get it done before they make it to her, but yeah, I definitely avoid doing them in the first 24 to 48 hours of life, because a lot of those babies don't breastfeed that well anyway. Like they're learning, you know, how to, and it takes a couple of days to really see what that tongue can do and what the baby can do. So yeah, it's a hot button issue for sure.
Any other questions? Check the chat one more time. Okay, well, in that case, Dr. Lombardo, thank you very much for providing us this talk today. A reminder that the link for CME reporting the survey to get you your credit is dropped in the chat currently. It's also in the email Bill sent out earlier today and whenever you registered. So please fill that out. It takes just a few seconds to do. And if I don't see any other questions, we will go ahead and adjourn and hope to see you guys next month. Thanks again.
Thank you all. Thanks for being here.
Thank you all. Have a wonderful evening.
You also.
See ya.